From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Health Tech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Good morning, Health Tech. I am coming to you from, we get a little feedback, David. I don't know if you can help on that. But I am coming to you from Nashville, and welcome everybody. I am delighted to join my co-host, or welcome my co-host, Elizabeth Ojo. Elizabeth is a licensed pharmacist with extensive experience implementing electronic medical records and managing clinical application products. Good morning, Elizabeth.
Hey, Jeff. Nice to be on the show again. I appreciate it. And I'm calling it. Oh, wait.
Go ahead. I'm sorry. I interrupted. Go ahead.
Oh, no. That's okay. That's okay. Happy to be back on the show and excited to chat with Kenny today.
And we are delighted to, as Elizabeth alluded to, welcome Dr. Kenny Cole. Good morning, Kenny.
Good morning.
So Kenny is VP of Clinical Improvement at Ochsner Health. I'm delighted to have Kenny here. Kenny is a licensed internist first and foremost. And prior to Ochsner, Kenny was Chief Clinical Transformation Officer for Baton Rouge General Medical Center, where he was the lead physician for health system and for the health system, and led all the strategic initiatives around value-based care. Kenny's helping at Ochsner. Kenny's helping drive, value-based care and helping make care more affordable and accessible for all. So, Kenny, can you tell us a little bit about your role at Ochsner and about what Ochsner 65 is?
Sure, happy to. Yeah, the title is a little vague, the Vice President of Clinical Improvement, but I like it because I think there's virtually nothing in healthcare that can't be improved. Along those lines, it's really a role devoted to clinical transformation. And so for health systems to transform to value-based care is really challenging because you're essentially having to decrease, utilization, which has been your primary revenue, to drive your economic engine. And so, leveraging new care models. And so, I designed, developed, and now lead Ochsner 65 Plus, which is basically a redesigned model of primary care that's multidisciplinary, team-based, integrated model of primary care where we manage a population where we bear the full actuarial risk on the total cost of care. So it's a reinvented business model where instead of our business model being driven, through volume and transactions, our business model is driven through value and outcomes.
So, Kenny, in the promo piece, one of the things we talked about, and it really came from our discussions, was the thought was when the ACA was passed and as we moved to value-based care, if we got the very best clinicians, and we found the best practices and gave them the best technology, that would be able to fix healthcare. And that really hasn't proven to be the case. And I'm wondering if you can just talk about that a little bit.
Yeah, that's right. And I think it's because what didn't change with the ACA, although we moved in the right direction, I just think it was one step forward in the right direction, is the fundamental economic model of healthcare wasn't changed. Instead, it was your fundamental economic model is still going to be volume-driven, transaction-based. It's a fee-for-service chassis. And now, yes, if you do a little bit better job, you improve some quality, we hold you accountable for these quality metrics, and you reduce, spending, then, now, you get to keep a portion of the dollars that, you reduced the spending on. And so it did provide some economic incentives to begin to transition towards value-based care. Although, having said that, there's a tremendous amount of expense that, happens with building out a clinically integrated network and developing all the systems and the processes that you now need to be able to monitor and track those quality outcomes and total cost of care and utilization And so I think some health systems have just struggled with how to allocate those investments when, again, their primary economic engine is still going to be the traditional business model of, people in the hospital beds, people undergoing procedures, imaging, the surgical services. That's still their main revenue engine. And so it really has not allowed you to transform the care delivery model in a way where, surgeries, procedures, imaging are expenses of the business model. And so that hasn't happened yet.
Elizabeth, did you have a question for Kenny?
I was just a little bit curious to maybe help understand, we definitely all want to be moving in that direction. And I'm wondering if you have a perspective on maybe the reasons that change hasn't, occurred as fast as we want. Do you think it's lack of motivation maybe from the clinicians, or it's just maybe hesitation in moving to a new business model? I'm just curious to understand where you think that slowdown is occurring.
Yeah, I think a couple of things. I think among the clinicians, first off, breaking down the clinicians into primary care and specialty care, and the specialists, most of the specialists, especially the most lucrative specialists, the ones who generate the most revenue for both the system and for themselves, that revenue is generated based on procedural and surgical services. There's a quote by Upton Sinclair that I really like that I think sums up a lot of what's happened in healthcare. It's impossible for someone to understand something if their income depends on understanding the opposite. And unfortunately, I think that may very well be true among some of my specialty colleagues, and it's also true among some health system executives, right? Who, again, their compensation is tied to a performance-based bonus. The performance-based bonus is tied to the financial health of the system. The financial health of the system is tied to an economic model, a business model that's entirely dependent upon economies of scale. And if you look at economies of scale, it's really about the production volume that you need to achieve in order to overcome your fixed cost. And these health systems have spent years, decades,
building in that way
a tremendous amount of fixed cost. And so before they can, turn the wheel, turn the wheel to a different direction or transform, I mean, they've got to cover those fixed costs. And then because you're talking about their fiduciary obligation to the bondholders, their obligation to their employees, right? Trying to avoid having to reduce your workforce. And so primary care, I think they don't quite fully understand, the position that they have in a value-based hierarchy of where they become essentially the drivers of the economic model for value-based care. I mean, they're used to being told the story of we can't even, the amount of money you generate doesn't even pay for your salaries, but we will, from a health system, will subsidize your income because you do create downstream revenue for us.
Right.
Referrals.
The entryways.
Exactly. Right. And so, but traditional health systems, I talk about traditional health systems and systems that deliver health, and traditional health systems really look at primary care physicians as loss leaders, which become acute care feeders to the higher margin revenue generating services. And so primary care is where the transformation has to take place. And I don't think they fully understand exactly their power under that new paradigm, where if all of a sudden you give the dollars to them as a population-based payment, and now their margin is based on reducing avoidable utilization, all of a sudden now the way primary care is designed transforms completely.
Right. That is such a good point.
That's really interesting, Kenny. Kenny, you talked about the kind of human element and designing the system from the outside in when we were doing the pre-call, and you're not going to get people to change their behavior, and you're not going to get patient engagement unless you earn their trust, and also unless you connect what they're doing to their life goals. And I can't remember the example you give, but you give a wonderful example of, people don't want to lose weight because they want to knock their A1C down. I think it was something about, maybe attending a grandchild's graduation or something, but Can you talk about how you use things like that to bring patients into your program and help them connect their health goals to their life goals?
Sure. Yeah, absolutely. Because I do think it's like finding that perfect marriage of digital versus human connection. And
Mhm.
I believe that if you were really to boil all of healthcare down to what is the single most important word in healthcare, at least in terms of driving improved health outcomes, I believe that word is trust. I believe it is earning the trust of a patient. I years ago I moved away. One thing I don't ever call a patient anymore. I've done it in the past, but it's been years. I never ever refer to a patient as non-compliant.
Yeah.
Non-adherent is not any better. Like, it's not the patient's job to comply with what I tell them to do. It's my job to earn their trust and then go on a journey with them where I help them to accomplish what matters most to them. And there's tons of literature to support this, right? That people are motivated intrinsically for the most part, right? If you look at Daniel Pink's work, where like extrinsic motivators, can be things like, for things that don't require a whole lot of, thinking or change, just routine, monotonous things, then, extrinsic motivators like, money, rewards to just sit there and do something that can motivate behavior. But they found that when like money was used to motivate things that were much more intrinsic, like achieving a deep sense of purpose and fulfillment, that money wasn't the most important thing. It became the intrinsic motivation. And this is for us as healthcare professionals. I know that's what motivates me, but it's also true of patients. And so what motivates patients are the things that matter most to them. And so one example, and I have tons, but I'll give an example of a patient who, their goal, like, and I just asked them, like, what are your goals? What matters most to you? What do you want to try to accomplish? And they wanted to be able to get on the floor and play with their grandchildren. So that involved needing to lose a significant amount of weight. And yet, they had been called non-compliant and they weren't taking their diabetes medicines and they weren't following a diabetic diet. And yet nobody unpeels the layers of the onions that are involved in that, which is that this person had adverse childhood traumatic experiences. This person developed a lifetime of maladaptive coping mechanisms through emotional eating and stress-related eating. And so their relationship with food was used as a coping mechanism. The PHQ-9, was very high, showing, significant depression. A G87 showed significant anxiety. And so there was no way to help this person begin to make progress toward their goals until you got all of those, in check, right? And so through integrated behavioral health, which is possible through a reinvented business model, where all of a sudden now a behavioral therapist is actually a cost of the business model because it's an operating expense, where your business model is reducing avoidable utilization and avoidable medical expenditures. The behavioral therapist now becomes one of the most important people in the team, and they're treating the underlying anxiety and depression through cognitive behavioral therapy as well as pharmacotherapy. You're, dealing with how to get them to stop doing the emotional eating and develop healthier coping mechanisms. And so a person like that, the person I'm talking about, had an A1C, a hemoglobin A1C, which is a measure of diabetes control, of 11. When I saw her, within 2 months, it was down to 7.8. And then within 5 months, it was 6.5. She had lost 35 to 40 pounds, and she was able to get on the floor and play with her grandchildren.
That's amazing.
Which was her motivator, right? It's about understanding what motivates them and then working with them together as a team. Yeah, it's the patient as a member of the team. In fact, the patient is the most important member of the team.
Yeah, and it's not just words. I love the idea of getting rid of that non-compliant kind of language, and that trust is so important. I mean, as a pharmacist, I've had so many patients. Once you actually understand, once you're able to build that relationship with them, and they trust you to actually explain what their motivations and their reasonings are, it never comes down to the patient just doesn't feel like taking their medication, or it's like, oh, I couldn't afford it this week, or, I got distracted or whatever. And if you can build that trust, not just to have like this professional and patient kind of relationship, but one where patients feel open and not judged, that is like the single most important thing. And it also gives the patient that kind of agency to own, how they want to express being healthy, right? Be it not necessarily a number on the scale, right? But because they want to be more active, because they want to take better care of their health, because they want to live longer. I completely resonates with me, and it's so true on the pharmacy side as well.
100%. And so what it is that, yeah, it's the non-judgmental is very important. And I will tell you that when you move away from that like judgment, and instead you move towards this kind of collaborative partnership built on earning trust, it is the care team's responsibility to earn the trust.
Exactly.
And when that happens, patients actually, like, they revert to the point where they don't want to let you down, because nobody has ever really done this with them before. Like, right now I run a clinic where 100% of our diabetics are controlled. And my very last diabetic, who was the one, when I got her, she was like A1C of 14 or something like that. And when we finally now just got her controlled, her words to me were just, "Thank you so much for just not giving up on me. And I want to be your best patient. I want to be your number one patient."
That's awesome.
Hey, Kenny, how do you, and you alluded to it a little bit, but you're talking about trust and making the transition from digital connect or human connection to digital connection. To do part of that, part of what Elizabeth is talking about, you have to allow people to feel vulnerable. And you have to get to the point where someone can say to you, "You know what? I'm too heavy to get down on the floor with my grandchildren, and I'm embarrassed about that," without, as you say, feeling judged. What are some of the things you try to do yourself and that you instill in your team to help them understand that? Because, for some people, that's very difficult because, honestly, as we talked about with, Sean Oliver a couple of weeks ago, some people have the attitude, it's like, hey, if you just had a couple more salads or you just walked a little bit more, you'd be better. So how do you help people, change that mindset?
Yeah, it's constant problem solving is what it is. And so, one of the things that I did, and again, it was actually at my prior system where I was the lead physician. And so I had some good political capital that I could do things that nobody had ever done before. And so what we were finding, we were utilizing both a dietitian and a behavioral therapist separately, which is the norm in healthcare. And what we found were that, people were like talking about emotional eating issues with the dietitian, and they were talking about other things with the behavioral therapist, but it was like a siloed approach. And so I basically just was kind of like, hey, look, why don't we like put the behavioral therapist and the dietitian in the same room, and let's just have the patient meet with both at the same time. And then now all of a sudden it was like magic, because, there was this triangulation that took place where all of a sudden the behavioral therapist is helping the dietitian and the patient solve the emotional eating issues. The dietitian is problem solving on other things, even things like, for example, we had a patient who, she worked 3 jobs and she relied on the bus for transportation. And of course, what's near a bus stop is fast food places. And so, she was eating fast food for many of her meals. And so the problem to be solved was, how do we get you healthy, nutritious food that is not fast food when this is your life circumstances? And so the dietitian is like helping her sign up for Amazon Fresh and how to get food delivered, fresh food, and going through the choices. Like, is this acceptable? Do you like this? But so it's not like what we do so much in healthcare. And I'm really picky about dietitians, because so many dietitians will just hand a person their, brochure, with the healthy options and say, you should be eating this and this. And, that doesn't work. Yeah. What works is finding out, like, what kinds of food do they enjoy, understanding their life circumstances, what gives them meaning. I remember having one patient who part of his quality of life was going over to his brother's house every Sunday because, and his brother would barbecue, and barbecue had lots of sugary, barbecue sauces. But this was such a source of enjoyment and fulfillment for this patient that we gave him that, we allowed that to happen. And so then we just focused on the whole rest of the week, and how do we problem solve for the rest of the week? And so it's just a very different approach of constant iterative problem solving through empathy and putting yourself in the patient's shoes and living their life with them and trying to figure out how to help them achieve their goals by overcoming the problems, barriers, and challenges that they face.
So Kenny, we've got a bunch of questions here in the chat, which is great. Let me see if I can read this first one. This is from Brian. Brian, thank you. The problem seems to turn on how to obtain evidence that putting a 36-year-old on a healthy path that will save costs when they're 76 years old. That is a 40-year lag and a pile of trust. And I think he's also alluding to, part of the issue is most people stay on a health plan for 2.5 years. Yeah. How do you convince a payer to, deal with something that, may have a, quite a time lag? So if you can talk about that a little bit.
That's a huge challenge. And he mentions a 36-year-old because that's where the biggest challenges lie, is in the commercial population. And the commercial payers, at least in our markets, have not, allowed us to have like risk-adjusted population-based payments where we're bearing the actuarial risk on the total cost of care. So where right now, where you can achieve the types of results I'm talking about are pretty limited to two payer domains. One is going to be the Medicare Advantage population, where you can take full risk and where you don't see sort of that same level of churning, and going through different MA plans. I mean, the whole thing there is, like loyalty. It's about, patient loyalty, patient retention, delivering through a better, customer service experience where they have no incentive to want to switch. And then the other payer domain is in self-insured employers where, and that's where I work at a system, we employ 30-something thousand people. And so we can build these types of advanced primary care models to manage our own population, right? Because we bear the actuarial risk on the total cost of care. And most of these people are working with us for many years. And so the cost savings benefits accrue to us. It's much tougher across the commercial payers, and I don't have an answer for that yet, other than they can't give me risk-adjusted population-based payments fast enough so that I can, develop care models that can service those payers as well. Yeah.
Elizabeth, do you want to take Sarah's question?
Yeah, let's see. Thanks, Sarah, for the question. What core values and strategies should one keep in mind if they're trying to solve value-based primary care problems with cloud-based online EHR or EMR software?
Yeah. So I believe the current iterations of EMRs, no matter which one you name, I mean, pretty much all of them are designed, developed for transaction-based care. They are not at all designed for value-based care.
Yeah.
And so, that's a big part of the battles that I fight every day, is how do we modify or make modifications to the electronic medical record that enable us to, to deliver the same type of care that some of my competitors do. So when I say competitors, I'm talking about entities like Oak Street or, Iora, which is now owned by Amazon, and ChenMed. All of them, they've developed their own, EMR, and they've done it because they designed it specifically, for the value proposition they're trying to deliver, which is not transactions, but rather improved health outcomes and reduced medical expenditures through better care. So all I can say is that we're trying. I was in Wisconsin, for the largest, one of the largest EMR vendors. I was there just about a little over a month ago, exactly talking about these types of things and showing them, what we're doing and what we need. And so we're in the process of just trying to modify our own electronic medical record to better suit our needs.
So you were in Wisconsin for one of the largest EMR vendors. Must have been an epic trip, Kenny. So let me take Christian's question, and then I'm sure we'll get a few more. But thank you everybody for your questions. Keep them coming in. I know we have one more after that. I do want to pose one more question from us before we get to Alden's question. So Christian said, so it really sounds like the primary care provider and the mental health provider are truly clinical quarterbacks of the VBC model. To align with the patient's wants and needs seem necessary for outcome success. Is this a correct assumption?
I think it's a correct assumption with a caveat. So I would tell you there's two types of value-based care models for primary care. There's going to be an incremental care model, which is what you find most prevalent across the country in terms of health systems that have attempted to do this. And when I say incremental, I mean they're participating in some value-based contracts. They now have a certain percentage of their income or compensation linked to value-based performance metrics, whether that's shared savings or just some type of care management fees associated with a quality-based contract. They're still on the volume-driven treadmill. Their primary income is still fee-for-service, RVU based. Like in my Ochsner 65 plus clinics, we don't measure RVUs. I could care less about RVUs. Our doctors maybe see 10, 12 patients a day. I mean, but the clinics can be profitable not through volume, but rather through the cost that you take out of the system. So there's incremental value-based primary care, and then there's transformational primary care, which is a completely redesigned model. In that case, in the transformational case, I actually like to think of the primary care doctor as the coach of the team. I have this great quote from Ronnie Lott that I show all of my doctors about how, great coaches lie awake at night thinking about how they're going to make someone better. That great coaches are like, great artists, trying to get the stroke on a painting exactly right, except they're painting relationships. And I love this quote, and I show it to all of our 65 plus docs because I tell them, you're the coach of a team. And I use the football analogy quite a bit because, the defense, that the patient is the one who has the ball. So we're on offense and we're going to try to help a patient achieve their goals that matter most to them. The defense that we have to go up against are the maladaptive coping mechanisms, the unhealthy behaviors, the burden of mental health, the burden of multiple overlapping chronic conditions, impaired social determinants of health, right? So the lack of transportation, the food insecurity, all of those, that's the defense. And so now the team and the primary care doc is the coach, and you've got a quarterback who's probably more like an advanced practice provider. And then, you've got your blockers, which include like your RN care manager and your behavioral therapist. And the whole goal is just to block the defenders and problem solve every step of the way in order to help the patient who has the ball make progress down the field to achieve their goals.
So Kenny, you've answered 90% of my question in terms of the difference between incremental and transformational value-based care. Can you how do you help set this up within the organization? What are some of the key things that you had to do to make Ochsner 65 a reality? What do you think are the key differentiators between that and an Oak Street and a 10 Med? You alluded to a couple of them, but as you're setting that up, how do you help your the CEO, CFO understand that?
Yeah. So the first thing, of course, was to develop the pro forma. So we had to create a financial pro forma that showed okay, if, and so working with a really good financial analyst to create this pro forma that will ultimately meet the level of scrutiny that the CFOs, and I'm in a big health system, and so there's lots of CFOs that sort of put their eyes on this type of a pro forma. And so essentially just kind of show them what could happen to profitability of primary care. Because normally, like I said earlier, their normal primary care are loss leaders, right? They subsidize them. They lose money for the system. Their job is to grow. Their job is a customer acquisition channel, right? To get new customers and feed the revenue service lines. With this, what we're showing is what if you created a parallel track of an advanced primary care model that works under a very different business model. It can become a primary care retention strategy because you know what, in your other model, your primary care docs are burning out. Look how many of them want to leave practice in the next few years. Mm-hmm. And so now what you can do is, instead of your primary care docs going to, the Oak Streets, which is now owned by CVS, the Chin Meds, which may be owned by Walmart one day, right? Once you're going to lose doctors to people like that if you don't do something.
Right.
And so there was this creating a financial pro forma, creating a business case, getting the CFOs to buy off on it, which they did. And then beginning to invest in these models and then show that the doctors are happier, the patients are happier, the outcomes are better. And so now what's happening is, how do we take learnings, from that and begin to apply that more broadly across all the rest of our primary care? And so now we've invented a track of value-based primary care physicians who are not necessarily within the domain of Ochsner 65 plus, but who nevertheless operate under a different business model where they're taking, only Medicare Advantage, Medicare, and members of our employee health plan, and then any products where we bear actuarial risk, on total cost of care. And we're setting up a parallel track of value-based primary care.
So Elizabeth, do you want to take Alden's question?
Yeah, absolutely. How can we possibly get enough? This one's an easy one, by the way, Kenny. How can we possibly get enough healthcare workers to achieve the level of transformation needed?
Super easy.
I think the answer, I believe very strongly that the future of primary care in particular is going to be APPs are going to outnumber the primary care physicians. And I think what you're going to see are primary care teams where one physician is working with 2 or 3 advanced primary care providers.
I think so.
And then I think what you'll need to do there is you're going to have a training curriculum for advanced practice providers and even for doctors, for both, to really learn how to deliver, sort of this type of value-based care. Because like what I do, I spend a tremendous amount of time teaching my doctors and my advanced practice providers how to manage chronic kidney disease, how to manage heart failure, how to manage COPD, how to manage hyperparathyroidism, because when you start letting the traditional model is, the doc doesn't have time to do any of that. They're referring all that to specialists, and then you get fragmented care and you get lots of clinically unwarranted practice pattern variation. But instead, if you just, the rule is that we're going to do evidence-based guidelines, and we're going to adhere to these evidence-based guidelines, and we're going to track, performance according to that, and we're going to train you how to do it. Then now they begin to manage a lot more of these things than before.
Did you have another question? Go ahead, Elizabeth.
I just had a quick comment. Everything you're saying today, Kenny, is the exact reason I love seeing clinicians in leadership roles, right, who are helping call the shots. I can't tell you how many times I've reported up to someone, someone who's graduated from business school and is telling me how to run a pharmacy. And I think that is part of the problem is when we have clinicians in these leadership roles, they're able to then put in place policies that help reduce burnout and actually make these environments places that people want to work in. So I just truly appreciate all the work that you're doing to create that kind of environment for sure.
Thank you.
So Kenny, one last question. You mentioned having, more APPs. There are a number of models which have, people who were, trained as Elizabeth is as pharmacists in the model. As a person who went to business school and teaches people who are MPHs and are going into hospital administration, how do you get the two sides to work better together? How do I help the students I'm teaching to, have more sensitivity to some of the issues that the clinicians are running into, at the same time, have the clinicians appreciate the financial side?
Yeah, the way that I've certainly tried to do it is one of the best books I've ever read was a book called Tilt. It was written by Niraj Dewar, who basically wrote an article about, tilting your strategy away from products and towards consumers. Tremendous amount of wisdom in this book because he gave the story of how he told the story of Richard Arkwright and, who was really the father of economies of scale. and how, all of the operating metrics and the performance metrics and, the financial metrics were all built around scale-driven performance metrics, which is traditional healthcare. It's all scale-driven performance metrics. But what a lot of companies are doing, and Amazon really sort of led the way, that a transformation to economies of scope, where, the fundamental strategic question for a scale-driven business is how much more stuff can we sell? The fundamental strategic question of a scope-driven business is what else do our customers need? And how do we earn more customers by overcoming their pain points, their challenges, their struggles, in order to grow the advocacy and loyalty of more customers, and therefore grow our customer base. And so if you think about health systems that are struggling, they're worried about eating into their traditional revenue by reducing utilization. And to succeed in value-based care, you have to do that. And so the only way to offset it is to grow more customers. And so the way that I had positioned Ochsner 65 Plus is this is going to become an enhanced customer acquisition channel where we're going to grow your customers by identifying pain points, challenges, struggles, earning their loyalty, going into markets maybe where we don't even have a presence. But because our business model is not dependent upon filling the hospital or referring to specialists, it's dependent upon exactly the opposite. And so we can go into markets where we don't have hospitals, where we couldn't traditionally go into, and we can gain more customers. And if we can meet a positive margin, because our business model is risk-adjusted population-based payment minus operating expenses minus medical expenditures, and the rest is margin. And so if we can create a positive margin and show how to make primary care profitable and make primary care docs happier so that we become the employer of choice for primary care doctors, we grow the amount of lives by doing that. And so I think telling the story in the business language to the business folks, and I love the economies of scope narrative because they understand that. They get that. They get how Amazon has become as successful as they've become.
So, Kenny, we have two more questions in the chat. I know you've been more than generous with your time. If you wouldn't mind taking one of them, do you have time?
I have time, absolutely.
Elizabeth, I will let you choose. How's that? I'll put you in the bad position.
Well, Sarah did ask hers first. Let's go with Sarah. Why would
and Michael, we will get to your, Elizabeth, we'll get to your question offline, Michael, I promise.
Yeah. Why are current EMR companies so reluctant to share patient data? And how can maybe new EHR companies who are trying to solve value-based care get into the market and grow?
Yes. So if you think about it, the traditional notion of a health system was to have a single EMR platform, right? We're going to have a single EMR platform, and we are going to now be able to coordinate care across a population because we've got this single EMR platform. And that was their strategy, right? Was just, in order to join with us, you've got to adopt our EMR, and we build all this kind of functionality into our EMR to make it better than other instances of the EMR, in order to try to show you why ours is better. And from the EMR vendor, it's kind of like, why would they want to share data? Because, from a business standpoint, it's really, they just want to, the biggest ones just want to lock up the market and become the only EMR vendor. And if they get enough market share and they get enough, patients, then all of a sudden, like, the only way to have coordination of care is to use that EMR vendor. And so I think that it's almost kind of a monopolistic mindset that drives that level of thinking. I believe it's a model that's going to get disrupted eventually by someone, because you're going to see new vendors come in who, how do they create differentiated value for doctors and for patients? And so we haven't talked about this. So, like, for example, one of the way digital meets human connection is, a lot of the stuff we do in my clinics are algorithm based. I mean, we manage blood pressure based on an algorithm. We manage diabetes with an algorithm. We have these very specified care pathways. Anything that can follow a specified care pathway, you can digitize it. And now all of a sudden the production of the outcome becomes more dependent upon following the digitized process. And so we'll build these kinds of care pathways into the electronic medical record to facilitate guided decision-making for physicians. So that's one way to do it. I think that the company that comes out, and I think generative AI is going to be a game changer, because the amount of data that generative AI can process, I just think that all of a sudden you start applying generative AI towards not the things that a traditional health system might apply it to, which is how do I become more efficient? How do I see more patients? How do I reduce the amount of waiting time? How do I, again, same old traditional operating financial metrics. All of a sudden you start applying generative AI to how can I improve health outcomes? How can I reduce the amount of specialty visits, for this population by getting more knowledge to the point of care in the hands of advanced primary care teams, that they can begin to make decisions that don't require specialist input, and how do I apply generative AI to understanding when I am having avoidable, medical expenditures, where are these areas at, and how can I begin to now tackle them with novel solutions? I think that's the future of healthcare, is how do I increase my margin through a different business model where my margin comes from that risk-adjusted population-based payments.
Well, Kenny, and I want to thank. I know we've got a ton of questions. Michael and Nathan, we will get to your questions offline. Kenny has been incredibly generous. I know Kenny's in clinic. So thank you very, very much, Kenny. This has really been enjoyable. Really appreciate it. And it's just wonderful. Thank you.
My pleasure. Thank you for having me.
So Elizabeth, I think what we'll do, just because, we did have a ton of questions with Kenny, is I'm just going to do one of the quick hits. I will post the rest up for, our producers. I'll post the rest up on our website. I just wanted to hit on one of them, and then we'll go to the two discussion articles in the interest of time. So folks, we typically do some quick hits, but we'll just go through one of them. One of them is United Health is facing a class action lawsuit over use of algorithmic care denials in its Medicare Advantage plans. And I think this is particularly important just because a class action lawsuit was filed against United, alleging that they're illegally using an algorithm to deny rehabilitation care to seriously ill as patients, and that United knew that the algorithm had a very high error rate. And part of the issue is that the lawsuit alleges United denied patients claims based on an algorithm, that they knew was faulty. And they also knew that only about 0.2% would file an appeal to overturn the insurer's decision. United has said that the insurers were only using the tool as an aid and not to make coverage determinations. But I think the suit illustrates both the increased focus on Medicare Advantage and coverage denials and the use of algorithms in care. And I think both of those areas are ripe for legislation and further regulatory oversight. So I wouldn't downplay the suit itself and the areas for care. And with that, I will move on to the discussion issues. Elizabeth, do you want to tee those up?
Yeah, we were able to read some really great articles this week. First one being how the changing ways that medical students are being taught in medical school, and how that's going to affect the provider population as a whole. Some of the highlights that we saw is that a greater emphasis on the soft sciences, which who's going to argue with that? Greater emphasis on being empathetic with patients, creating a more wholesome kind of experience for patients, along the lines of some of the things we talked about with Dr. Kenny, where you're really emphasizing the importance of mental health, of psychology, of sociology, and how that really plays a part in actually improving patient outcomes. Because as we all know, people are not just numbers on a chart, or they're not just their chart. They are real lived people who are going to have to you have to like problem solve in the moment with this person and take their unique experience. You take their unique experience into consideration for whatever your care plan is going to be. So those are some of the highlights that I really appreciated seeing. That there really wasn't anything I saw in there that, at least to me, felt really controversial.
It's interesting because when I first saw the article, I really thought they were going to talk about physicians learning or needing to learn more about incorporating technology and AI and other things into it. And it was a much lesser extent or portion of the article. As you talked about, it really talked about emotional intelligence, social skills, the importance of diversity, equity, and inclusion, and understanding and working to understand, as you said, lived experience and some of the things Kenny referred to. It did touch on, which I think is extremely important, the need to use other tools. But I was really, a little surprised and unpleasantly so that you need to use these other things. But I thought that was a really good skill set that physicians need to use better.
Yeah, I did see that a little bit, and I wonder. I think my theory for that is that I just wonder how, if it's possible that, you teach a first year medical school about AI, by the time they get into practice 8 to 10 years later, it's like, is
Yeah.
that, I mean, technology just moves so fast, that I would love to see maybe an increase of that kind of education, right? Like in the moment, right? When they're actually like being residents and applying it in their day-to-day life, because then that's the actual technology that they'll be using rather than something that they learned 4 or 8 years ago in school. I'm wondering if maybe that was the reason, but who knows?
Yeah, I do think at some point you'll have to see some like CE credits for AI and
Yeah,
technology learnings
sure.
and AR VR.
Yeah.
Well, let me touch base on the next article. I know we've gone quite long on time, but article on Medicaid enrollment and spending growth amid the unwinding of the continuous enrollment provision fiscal year 23 and 24 from the Kaiser Family Foundation. The article was basically noting that Medicaid enrollment increased 23 million between February 2020 and April 2023. So during COVID, the federal government provided funding for Medicaid and to the states, for Medicaid to the states to allow them to not disenroll people because they needed care. Now the states will have to redetermine eligibility for all Medicaid enrollees, and they're disenrolling people who are no longer eligible. The big issue is that people may not remain eligible or may be disenrolled because they weren't able to complete the enrollment process. So to date, more than 10 million beneficiaries have been disenrolled, and that's significantly higher than about 6 million or 6.6 million in September. Tremendous variation in the states. Texas has about 65% have been disenrolled, and Illinois only has about 10%. And a lot of this is due to that administrative problem. People don't know that they had to re-enroll. They may have moved, they may not have gotten the notice. And I think this is a big issue. The HHS has put a hold on this for a number of reasons, but I do think this is an issue both because people shouldn't be disenrolled because they can't administratively qualify, but also for hospitals and other providers. This is going to create a tremendous financial strain because while Medicaid doesn't pay a lot, as Kenny alluded to, some of it does cover some of that fixed cost for hospitals at least. And I think this is a bigger issue. I was just wondering what your thoughts were, Elizabeth.
Well, I mean, it's unfortunate anytime someone loses access to healthcare. I mean, and we're talking about millions of Americans now not being able to, being unenrolled. I mean, it's just unfortunate. And just to compound it more, it's, a lot of this is due to administrative, administrative issues. And it's just like how it feels unreal, honestly, and I'm surprised I'm not like seeing more headlines about this because it really feels like its own, a really big issue. And it's just unfortunate, both like you said, for the patients as well as these health systems that are counting on that income that they've been used to through the pandemic. We know that a lot of policies have been unwinding as we're getting out of the pandemic, but this one truly does seem unfortunate. And I'll be curious to see what the continual impact looks like throughout 2024. And hopefully we'll see if there's going to be some reversals or ability to increase that funding again, but we'll see.
Yeah, and I do think I think this is really a big issue, and part of the thing that concerns me is that this got a lot of publicity up front, and I think, as you alluded to, it seems to have gotten into the background, and I think it's going to be a big issue. This is not. We are going to have one of the principals from Health Management Associates. We're finalizing the date in a couple of weeks to talk about redeterminations and the redetermination process. So I'm looking forward to that. With that, I want to thank everyone. Alden, Sarah, Michael. I apologize, I'm forgetting a couple names, but thank you very much for your questions. Please do keep them coming. Please do join us next week. Thank you very much for joining us. Next week, we will have Susan Winkler and Carla Rodriguez Watson from the Reagan-Udall Foundation from the FDA, talking about the need to reach and have diverse patient populations in clinical trials, and ensuring that you reach diverse patient populations to make sure in your trials and within some of your drug research work. I want to thank you for joining us. Please check out our blog this week. It's on ventricle health, accelerating evidence-based care for heart failure. They're doing a great job. We're going to try to have them on as well in terms of congestive heart failure, which is near and dear to my heart. Unfortunately, my dad passed away from CHF. Please check us out at Healthcare Strategy Bullpen, on Twitter at Healthcare Pen, on LinkedIn at Healthcare Bullpen. And one of the reasons we're down here in Nashville is looking at companies. We look at thousands of companies a year, for payers, providers looking for the right solution. We talk to companies, we talk to payers, we talk to 3 different health innovation teams at hospitals and providers, 4 startups, helping them get them into the innovation ecosystem. So please reach out to us, because that's what we do. Is we serve as the interface between the startup ecosystem and helping get you and navigate the dynamics of selling into healthcare, and for the healthcare systems, helping them find the right solution for their problems. And with that, I will turn it over to you, Elizabeth.
Thanks, Jeff, and shout out to the viewers for being really engaged today. We really do appreciate all your questions and comments. Feel free to subscribe to the show by scanning the QR code on the screen. You'll get weekly invites. You can also email us at any time with questions, topics, guest ideas, or anything else. Our show is also sponsored by Redox, the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. From all of us at Diagnosing Health Tech, thanks for watching. See you next week.